Hi, everyone. We can get started. I can advance the slides. There we go. Okay, so today we will cover some topics, including our normal epi surveillance for respiratory diseases. We'll go through some TB requirements for healthcare facilities because we've been getting a lot of questions about that with the risk assessments you need to do. We're going to ask for some feedback about the hand sanitizer we distributed to you last year. Tom's going to do an MDRO presentation. We're going to highlight Mercy Circle for some cool practices and then go through some upcoming events. As always, feel free to ask questions during the presentation in the chat, or you can come off mute. So first, in terms of variants, again, it's all Omicron still, so nothing's changed at that much on that point. However, there is a new variant called NB.1.8.1, which is still Omicron that has been causing a surge in Asia. And it has been spreading, so it's in 20 countries, including the US. I don't think there's been any identified cases in Illinois yet, but that could have changed since I made this slide. There's not any indication that it's more severe than recent variants, so I'm not expecting like a higher proportion of residents who have it to be hospitalized or have death or anything like that. However, it does seem like it's easier to transmit. So if you do see a spike coming up, it might be because of this. But the vaccine that everyone should have gotten already should still provide protection against severe disease. And again, this is still Omicron, so it's still in the same kind of family. But anyways, in terms of surveillance, as you can see here above the red circle a little bit, the prevalence of COVID in terms of all respiratory specimens that have been tested is very low right now. It's 1.7% of specimens that are tested are positive. So that might tick up a little bit again if this variant spreads rapidly in Illinois.
Yes,
but in terms of,
how are you?
oh, if everyone can mute, that would be helpful. Let me see if I can mute. Hold on. Okay. But the main thing that's circulating right now in terms of people being sick from respiratory diseases is rhinovirus and enterovirus. So that's basically the common cold. That is the highest percent positivity in the respiratory specimens. So everything else, flu, RSV, are pretty low right now. And this is reflected there. Again, bottom left, you can see rhinovirus and enterovirus ticking up. COVID in the middle on the top is going low, but then it might spike again. So we've gotten a lot of questions recently about what you need to do in relation to TB. So I wanted to go through that. The first thing you need to do is a risk assessment for your facility. So that should be right away and then ongoing. You have to have a couple of different things, including kind of the administrative, environmental, and respiratory protection controls you have in place. And that risk assessment should be reviewed at least once a year. There's also should be a written plan which has to be updated at least once a year. And that needs to include how you guys are going to screen and manage for latent TB infection for staff and residents, how you're going to screen, diagnose, and manage any residents or staff with active TB, how you're going to collect and evaluate data, how you will report people who have suspected or confirmed active TB. Reminder that latent TB is not reportable. How you're going to educate your staff. You have to have someone designated to be the contact person for TB prevention and control, and that needs to be included in your written plan. And then also a referral mechanism if you do, sorry, it shouldn't say clients, it should say residents. If you do have a resident with TB, active TB, again, they should not actually be in your facility while they're actively infectious. So you need to have a referral mechanism for those residents who leave the facility and go somewhere else. You also need to have a TB prevention and control program, which is basically just the operationalization of that plan you have written. And you need to provide education. So all healthcare workers at your facility should be trained upon hire and then periodically afterwards to make sure they know about TB and the level of risk in your facility. You need to make sure you're collaborating with us and IDPH in the event that you do have any cases. We might be asking you, let's say you have an active case in a resident, we might be asking you for some contact tracing. There might need to be some additional testing. So we would reach out to you, or our colleagues in another part of CDPH would reach out to you to coordinate that, but we expect your collaboration on that. And then you do have to have records about the screening test results, any diagnostic evaluation results. If anyone was exposed to TB. So again, if we have an active case in your facility, you should keep records about who you deemed to be exposed and whether they got tested and those results. And then your current written plan. You should analyze that data every once in a while, and records must be made available to public health upon request. So there are some resources that will hopefully be helpful for you. One thing we get asked a lot is like, what is this risk assessment and where do I find it? So there is some old guidance from CDC that actually includes an appendix that has this risk assessment worksheet. So if you don't have that already, the link is on the bottom of this slide. And then also Allie is getting it put on our website and we can send that to you as well. So if you go to this very long document, and go to page 128. This form is there and you can fill that out and that will be sufficient for your risk assessment. There's also an Appendix A, which is on the page before, that has examples of the administrative, environmental, and respiratory protection controls that would be applicable for your setting. So you can throw those into your plan. And then there's a risk classifications table on page 134 that you can use as well, because I think it asks you somewhere in here, what's the risk classification for your inpatient or for your setting, and that's under the risk classification section of this form. And from what I can see, if you've had less than 3 cases in a year, you're all low risk. So if you think you're medium or high risk, reach out to us, but you're probably wrong. Okay. And then another question we get a lot, because on this form, as you can see at the top, it has what are the rates of TB in your area. So this would be that form. It's again on our website now. We can send it out to you. IDPH publishes this every year, but it has the rates for the US, the state, and Chicago, and you can just plug that data into your risk assessment. And then we also have a lot of resources on our website, which hopefully you're all familiar with. It is the links included in your the email, that we send after the follow-up calls as well. And now, so hopefully you remember that last year we sent or delivered, I think, about 8 boxes of hand sanitizer to each of your facilities. I'm actually presenting at a conference next month where I'm going over the focus groups and the distribution of that hand sanitizer. So if anyone feels so inclined, it would be amazing if you found that those were helpful, if you could just throw a little statement in the chat about how you use them, if staff were appreciative, if they were helpful. If you could throw that in the chat, that would help me out a lot for my presentation. And then the IPs are also going to be asking you about that on our follow-up calls. Okay, now I'm going to pass it over to Tom to talk about MDROs.
All right. Thank you, Liz. Good afternoon, everyone. Thank you for coming. I'm Tom Room. I'm the CDPH infection prevention specialist for ventilator-capable skilled nursing facilities, long-term acute care hospitals, and specialty hospitals. So today we're going to be talking about multi-drug resistant organisms, the threat they pose, as well as their prevention and mitigation. Next slide, please. We'll start out with some learning objectives. So those are to discuss antimicrobial resistance, multi-drug resistant organisms and the threat they pose, discuss the transmission of MDROs in healthcare settings, and discuss the importance of proper infection prevention and control practices as related to MDROs. Next slide. So just as a quick introduction to MDROs, as many of you know, MDROs are microorganisms or germs, most often bacteria, that are resistant to one or more classes of the antimicrobials used to treat the infections they cause. Examples of bacterial MDROs would be like CRE or crab. However, not all MDROs are bacterial. For instance, C. auris is a fungal MDRO. So as far as what causes the development of antimicrobial resistance and MDROs, the simplest answer is they're caused by antimicrobial drugs. When we use medications like antimicrobials, they kill all the target germs that are susceptible to them. And this creates what's called evolutionary pressure. And all that really means is that these germs need to figure out a way to evolve in order to survive the threat of the antimicrobials they're being exposed to. And so as a result, as they develop this resistance in order to survive, treatment with antimicrobials only leaves the germs that are resistant to them behind after treatment. It's also important to note that even when antimicrobial drugs are used correctly, uh, there's still a risk that antimicrobial resistance will develop. Of course, the risk is greater and resistance develops more quickly when antimicrobials are used inappropriately, but the development of resistance is inevitable. Um, it's going to happen no matter what. So overprescription of antimicrobials like antibiotics um, are a major issue because they allow resistance to develop more quickly. Um, Often, antimicrobial prescriptions aren't necessary in the first place. In the US, each year, there are 40 million prescriptions for antimicrobial drugs, um, which are unnecessary, meaning that they have absolutely no benefit for the patient. And that number represents 30% of all the antimicrobials prescribed in the US each year. Um, Unfortunately, while we have this continuing threat of resistance developing, the rate of new drug development for antimicrobials is simply not able to keep up with the rate at which resistance develops. So, for instance, in the last 30 years, there have been no new classes of antibiotics developed, even though we have that current, rapidly increasing um, antimicrobial resistance to them. So as a result, besides antimicrobial stewardship, which is, of course, practices to improve how antimicrobial drugs are used, infection prevention and control is really one of our main tools to prevent the development and the spread of antimicrobial resistance. If we can prevent these infections, if we can prevent, I suppose, infections in general before they happen, then we can reduce the use of antimicrobial drugs because we don't need to treat the infection that we don't have. Um, and they also help reduce the likelihood that that resistance will spread once it has developed by containing MDROs and other antimicrobial resistant pathogens. Next slide, please. So why is antimicrobial resistance such a big problem? The answer is the consequences of antimicrobial resistance can be quite serious. So in 2019, antimicrobial resistant infections directly caused 1.27 million deaths and contributed to a further 4.95 million deaths. In the US alone, antimicrobial resistant infections incur about $55 billion in healthcare costs each year. If we divided those costs up, that's roughly $166 per American per year, just caused by these antimicrobial resistant infections. And as I said, the situation is continuing to develop, and more resistance is developing amongst pathogens. The World Bank Group performed a study and they found that if current trends continue, by 2025, antimicrobial resistance will cause 10 million deaths annually and incur economic costs of between 1 and 3.4 trillion US dollars annually. With the economic costs there, that is roughly the same as the economic damage that we saw in 2008 during the Great Recession. However, instead of being more of a one-off event, those economic losses would be continuing year over year, which would really be devastating. Next slide, please. So there are two quotes here that I think are really helpful. The first is from the CDC's Antimicrobial Resistant Threats Report 2019, which says, "Stop referring to a coming post-antibiotic era. It's already here." And in addition, the World Health Organization has said that antimicrobial resistance is one of the top global public health and development threats, with development there kind of alluding to the economic costs of antimicrobial resistance. Next slide, please. So now that we've kind of reviewed why this is such an important problem, let's discuss what we can do. And one of the most important ways to be able to address a problem is to understand it. So we're going to start with understanding MDRO transmission. Next slide, please. So first, let's look at the population who's at risk here. Individuals at particularly high risk for MDRO infection and colonization are older adults or very young children, people who have more than one chronic health condition, have multiple stays or have stays in multiple healthcare facilities, as well as indwelling devices and mechanical ventilation. Next slide, please. And a lot of these characteristics are present in the resident population of long-term care facilities. So I recognize that mechanical ventilation is not all long-term care facilities. That's, specific to ventilator-capable facilities. However, the majority of these are highly present, especially the older age, chronic health conditions, stays in multiple facilities. Next slide, please. So as far as the two main approaches for controlling antimicrobial resistance and MDROs. First, we have antimicrobial stewardship, which I mentioned earlier. And essentially, antimicrobial stewardship attempts to improve the way that we use antimicrobials and how we prescribe them. And the goal is to prevent and slow the development of antimicrobial resistance by improving those practices and making sure we're using the right antimicrobial for the infection, that we're using the correct dose for the correct duration, things like that. Infection prevention and control, while not necessarily directly related to the development of antimicrobial resistance, at least not as much as antimicrobial stewardship, is still very important. Because we are able through infection prevention and control to prevent infections from happening, we can prevent antimicrobial use that would be used to treat them, thus reducing the rate at which antimicrobial resistance would develop. In addition, because we're also preventing the transmission of infections, it helps contain the MDROs and the antimicrobial resistance that we already have. And then finally, infection prevention and control practices help reduce the length of stays in healthcare facilities, as well as treatment costs. And again, these also help kind of, by reducing the length of stay, we reduce the likelihood of exposure to these MDROs. And by reducing healthcare costs, we're also helping to ensure that there are funds available to continue additional programs and things to help target these pathogens. Next slide, please. So now getting into specifically how most of our MDROs spread. MDROs spread by contact transmission. And what that means is that they need to hitch a ride on something in order to get around from an infected or colonized individual to a new susceptible host. Some of their favorite ways to do this are on unwashed hands, on clothing or linens, equipment like stethoscopes or blood pressure cuffs, the Hoyer lifts, and then, of course, environmental surfaces, so tables, toilets, light switches, bed rails, computers, countertops, things like that. So when an MDRO reaches someone who is susceptible, meaning that they can become infected or colonized, that's when we actually see transmission. So as a result, we have three main practices that are very effective for introducing this route of transmission. So hand hygiene, which of course makes sure that germs that spread by contact aren't present on our hands while we're providing care, and also aren't present as we leave the room for us to then contaminate environmental surfaces. Environmental cleaning and disinfection, which is important to make sure that any contamination present is removed. And then transmission-based precautions and PPE use. These also help to make sure by adding kind of an additional barrier, an additional layer of protection, that we minimize the likelihood that we become contaminated when we are providing care or have contact with residents and surfaces. And then also by removing it when we leave, making sure that we're not continuing to spread that as we go about our day. Next slide, please. Hand hygiene is likely the single most important way that we can prevent the spread of MDROs. And this is because we use our hands for nearly everything. They're essential. Every time we interact with a patient, every time we interact with the environment, virtually every time we do anything, we're going to use our hands. And germs that spread by contact count on that. They absolutely depend on it. Most MDROs that spread through contact, either our hands can become contaminated while providing care, and then we go and touch something else and contaminate the environment. Or if we don't wash our hands, we risk bringing MDROs into a room from a contaminated environment or surface or another resident room where we recently were. Next slide, please. So I included this image. I believe this is from the World Health Organization. It's the 5 moments of hand hygiene. Many of you have probably seen this before. The 5 moments of hand hygiene are a set of evidence-based practices for performing hand hygiene that essentially say what opportunities there are when we should be performing this activity. So one is before touching a patient, which can also be before entering a room. 2 is before a clean or aseptic procedure. 4 is after touching a patient or before leaving a room. Did I miss 3? After body fluid exposure is 3. And 5, after touching a patient's surroundings. So even if there's no patient in a room, if it hasn't been cleaned since they left, surfaces could still be contaminated. So next slide, please. Now we'll go through a little bit some of the rationale here. So we want to perform hand hygiene before we enter a room. And this is obviously so that we don't bring any contamination or germs into that encounter from outside the room. So whether that's something we're bringing from the last resident encounter, from a computer or nursing station, we want to make sure we're not bringing anything in. Before a clean or aseptic procedure, so specifically I like to think of placing a urinary catheter. We want to make sure that we're not bringing any germs there because that procedure is clean or aseptic specifically because there's a risk for infection, right? We don't want someone to develop a urinary tract infection, a CAUTI, using the example I mentioned. And that contamination can come from our hands, the environment, or even the patient's own skin. Next, we want to perform hand hygiene after resident or patient contact, and this is so we're not bringing anything out of the room where it could then, either our clothing, our hands could contaminate surfaces in the next resident room or bring it directly to the next resident. We don't want to contaminate high-touch surfaces or equipment or the nursing station, so we need to perform that hand hygiene as we leave. After body fluid exposure, I think this one is pretty obvious because body fluids can be contaminated by a whole host of germs, microorganisms. So we always want to make sure that we prevent contamination. So if we were just handling or draining a urinary catheter collection bag, we want to make sure that we perform hand hygiene right after that. And then finally, after touching a resident or patient or their surroundings, and this is so that we don't bring anything out of the room and contaminate equipment elsewhere. And it's important to note that these 3 on the right, while the risk of someone, a healthcare worker at a long-term care facility being susceptible to these MDROs is very low, these hand hygiene practices, they apply to all pathogens. So these 3 practices do also serve to protect our healthcare professionals. Next slide, please. So in order to kind of demonstrate visually how this kind of chain works, I created this diagram. So the boxes, which the striped boxes with hand hygiene over it, that represents our opportunities to perform hand hygiene. Um, in this diagram, it would have become too complicated if I tried to include all 5 opportunities for hand hygiene. So we're only doing on room exit and on room entry. So we start here on the left with an MDRO positive resident. So there's a caring counter, and we're going to say that as the healthcare professional leaves the room, they don't wash their hands. And so that can result in 2 things. Their hands will likely be contaminated, and then their hands can contaminate surfaces or objects that they come in contact with. It's also important to note that even if they do perform hand hygiene as they leave, it's possible that contaminated surfaces or objects could contaminate their hands before they get to the next patient. And that's why we need to perform hand hygiene at the next opportunity, which is on room entry for the next patient. If both of these opportunities or one of these opportunities are missed, there is a likelihood that we could expose the susceptible resident. And in that case, they could become colonized or infected. And then the cycle kind of repeats with that resident. And so if this kind of chain is uninterrupted by our infection prevention and control practices, it's essentially a highly simplified model of how an outbreak could occur, with only one practice. So as we have more MDRO positive residents, we also have more opportunities for contamination and more opportunities for exposure of susceptible residents. Next slide. I did also quickly want to include some information about the 2 methods of hand hygiene. So we've got alcohol-based hand sanitizer and soap and water. Alcohol-based hand sanitizer will kill the germs on our hands, and it is preferred in most clinical situations because it's easier to make available, it's faster to perform, and it's less drying and damaging to hands. So this is kind of our go-to. But there are situations where we need to perform soap and water hand hygiene. Alcohol-based hand sanitizer doesn't actually wash anything off your hands. It kills the germs, but it leaves things on. So if our hands become visibly soiled, meaning that they're dirty, then we need to perform soap and water hand hygiene to wash that dirt off, because it could essentially protect germs from the hand hygiene or from the hand sanitizer if we were to use it. There are, of course, also certain germs that are not susceptible to alcohol-based hand sanitizer for different reasons. C. diff because it's spore forming, and norovirus because it doesn't have a membrane for the alcohol to disrupt. So for those germs, we also want to use soap and water hand hygiene. Finally, after using the restroom and before and after eating are also opportunities where soap and water hand hygiene is preferred to alcohol-based hand sanitizer. Next slide. So as we mentioned earlier, there is an interplay between hand hygiene practices and our environmental cleaning and disinfection. We want to make sure that our hands don't become contaminated from the environment and vice versa. So cleaning and disinfection are critical to this. We want to make sure that high-touch surfaces are being cleaned at least once a day. And while cleaning, it's really important to know those contact times, which is, of course, how long a surface needs to stay wet with the disinfectant to kill the germs it's supposed to kill. So making sure that anyone who has cleaning duties is aware of those contact times and is leaving the product on that surface for that full contact time is really important. In addition, we want to make sure that we're not dragging contamination from a dirty area of the room to a clean one. So when cleaning an area, we always want to clean from top down. We do that because if we started from the bottom up, there's potential that dirty cleaning disinfectant fluids could run down the wall, contaminate the area we already cleaned. And then we want to go from clean areas of the room to dirty. We'd never want to clean the bathroom first and then use the same supplies to clean the rest of the room, because that's the dirtiest area of the room. And there's the potential there to drag that stuff into cleaner spaces. Next slide, please. This is a very similar diagram to what we looked at earlier for hand hygiene, except it is for environmental cleaning and disinfection. So on the left, we have one, which is our colonized or infected patient with an MDRO. And of course, because these MDROs very commonly live on the skin or, cause contamination very easily, there's potential that they can contaminate surfaces in their room, and that surfaces can also be contaminated, as we talked about, by hands. So we have this opportunity, 3, to clean and disinfect contaminated surfaces before they reach either healthcare personnel's hands or directly reach a susceptible patient. So if we miss this opportunity to clean and disinfect, then we have 5, which is an exposed resident becoming colonized or infected. And then the cycle kind of repeats itself. So our environmental cleaning and disinfection is a key opportunity here to prevent the chain of infection and prevent these MDROs from reaching someone who would be susceptible to infection. Next slide, please. In addition, we do have 2 very important practices, contact precaution and enhanced barrier precaution. So I'm sure that you guys are familiar with these, so we'll go through it kind of quickly. We use contact precautions often during active MDRO infection or when someone is otherwise at increased risk of spreading colonization of these MDROs. And one of the main indicators for that, main reasons for putting someone on contact precautions would be if they have secretions or excretions that can't be controlled. So whether that's urine or feces, whether they have a wound that's weeping that can't be controlled by bandages or anything like that, those fluids and materials are going to contain a lot of these MDROs. So temporarily, those individuals can be put on contact precautions in order to help contain that. And with contact precautions, we always use gown and gloves in a contact precaution room. Everybody needs to. And then with contact precautions, residents also remain in their rooms unless they need to leave for a medically necessitated treatment or something like that. With enhanced barrier precautions, these are used for a couple of reasons. So if someone is colonized or infected with an MDRO, or if they have wounds or indwelling devices, and secretions and excretions can be controlled. And so in those situations, with enhanced barrier precaution, we use targeted PPE. So that would be gown and gloves, specifically during high contact care activities. And of course, residents can leave their room. Enhanced barrier precautions are designed to be used more in the long term. Next slide, please. So when do we use our gown and gloves during or for enhanced barrier precautions? So those high contact activities are going to be dressing, bathing or showering, assisting with transferring or repositioning, hygiene needs, and most of the activities of daily living, changing linens or assisting with briefs or toileting, indwelling device care or access, and wound care. For other activities, gown and gloves are not necessarily required. It is a good idea if you're performing some kind of activity that maybe isn't on the list, but your hands or body are going to have extensive contact with the resident or their surroundings. It's a good idea to cover those areas. So if you're going to be touching all kinds of stuff, consider wearing gloves. If your body, your clothing is going to come up against something, it might be a good idea to wear a gown. And then of course, standard precautions still always apply. So there may be additional PPE that you need to wear in some situations. So for instance, if there may be sprays or splashes of body fluid, you may have to wear a face shield or eye protection. But as far as what is required of enhanced barrier precautions, that's kind of the summary there. And speaking of summaries, next slide. So we talked about how residents in long-term care are at high risk for severe illness and even death from MDRO infections. We talked about the spread of MDROs and their antimicrobial resistance and how this is a direct threat to our ability to use drugs to treat infections. And if we're unable to use those drugs, our antibiotics, our antifungals, um, that is going to result in increased morbidity and mortality and economic costs. So one of our best ways that we can prevent MDRO transmission is going to be through high quality hand hygiene, environmental cleaning, contact and enhanced barrier precautions, and appropriate PPE use. These are simultaneously the most basic practices, but they're also the most important. Um, they are really the groundwork for any infection prevention and control program. Next slide, please. So now we have some questions for you guys to kind of check your knowledge. So next slide. So our first one is a healthcare professional always performs hand hygiene when leaving a residence or when leaving residences' rooms, but doesn't always do it before entering. Does this increase the risk of MDRO transmission? And A is no, because performing hand hygiene when leaving the room prevents us from bringing germs out of the room. B, no, because outside of residence rooms, surfaces are considered clean. C, yes, because if we touch something in the environment with germs on it before our next care encounter, but don't perform hand hygiene before entering that room, we'll then expose residents to those germs. And D, yes, but not enough to make hand hygiene worth it. You can either put your answer in the chat. You don't have to. We'll give you guys a little while. All right. Next slide, Liz. So yes, because if we touch something in the environment before that encounter, we could contaminate our hands and then bring that into that next resident. And of course, we want to try and avoid bringing anything into the rooms. It's not just MDROs, but there are also a lot of other threats out there. So yeah, we definitely want to perform hand hygiene before entering. Next slide. True or false? When we're caring for residents with MDROs, we can know with certainty that the MDROs only exist on surfaces inside the resident room because hand hygiene, transmission-based precaution, enhanced barrier precautions, and environmental cleaning and disinfection ensure containment. Need some Jeopardy music. All right. Next slide, Liz. So false. So it is correct that all of these practices are designed specifically to contain, um, MDROs or whatever pathogen we're using them for. But 100% containment isn't possible, um, at least without really, really advanced methods. So like a biological safety level 4 lab. So while they do help us contain these things, we can't ever say with certainty where these germs might be. And that's one of the reasons why we have to be so careful and make sure that we're always doing, our hand hygiene when we need to, that we're performing really high quality environmental cleaning and things like that. Next slide. And I think this is our last one. And that is what is likely the single most important practice for preventing infections in healthcare settings. And now, of course, this can change with the situation, but kind of overall. Next slide, Liz. Hand hygiene. And one of the reasons for that is that we depend on hand hygiene to help keep our environmental surfaces clean. So even if, we're doing great cleaning, if we're constantly recontaminating them, hand hygiene can kind of undermine that. And the same with proper transmission-based precaution. Um, you know, Even if we're wearing all our PPE correctly, we need to be performing hand hygiene as we take that stuff off and before we put it on. Um, the risk of self-contamination especially as we take off PPE, is fairly high. So we need proper hand hygiene techniques to make sure our transmission-based precautions work. And the same thing with proper PPE use. Even if we're doing our best to do everything right, PPE is not 100%. We can sometimes contaminate our hands as we take our gloves off, or our arms as we take our gowns off. So it's always good to make sure that we're backing up all of these practices with really solid hand hygiene. Next slide. Oh, right. I forgot about my little explanations, but you guys can read those later. It's essentially what I just said. We can go to the next one, Liz. All right, and that's all I have. I'd be happy to take any questions if anyone has any. Um,
Okay, thanks, Tom. We just
hmm,
have a couple more things to cover. One thing that I wanted to cover is that we went out and did an ICAR at Mercy Circle recently, and we were asking our normal questions, including how it's staff are aware of what equipment has been cleaned or disinfected. And they are the first facility that I've seen that has these handy stickers where they can put it on equipment like wheelchairs or things like that to say that it has been cleaned, when it was cleaned, and by whom it was cleaned. So that's a clear indication that it's ready to be used. So love that. They also had a very cool technology thing in their memory care unit if anyone wants to reach out to them to ask about it. And then there's a couple upcoming events I want to mention. One is a webinar for LTC outbreak management. It's put on by APIC and the American Association of Post-Acute Care Nursing. So it's specific to long-term care. It's on June 26th at 2 p.m. and I have the registration link there. And that'll also be added to our website. There's also the Cook County Infection Prevention and Control Conference for long-term care. So that's coming up soon. It's June 4th. I did reach out to Mabel at Cook County and she said that registration is still open. So if this is something you're interested in, I'll hold the slide up for a second. Use that QR code right there. Otherwise, it's on our website as well. This is already on our website in upcoming events. So again, I'll wait a second for you to grab your phones and take a picture. For that, there is our CEUs available and it's free. So that's good.
It's also in the chat.
Oh, perfect. Also in the chat. Thanks, Allie. And then just a heads up that since we've already talked about everything that's ever happened in long-term care on these roundtables over the last 5 years, we're going to switch from monthly to every other month. So they used to be weekly during the height of the pandemic. Then we went to monthly when things slowed down. And then, yeah, we're going to move to every other month just so we're not just telling you the same content over and over. If there's anything that comes up, like if there's an outbreak of some new pathogen that you're not used to in your facility, then we'll schedule kind of an ad hoc update. But so based on that, our next roundtable will be July 24th. You might have noticed that you don't have any invites for the upcoming roundtables. One of my colleagues is going to send another round of update or invites for the rest of the roundtables in 2025. So you should get that within the next couple of days. And if anyone else at your facility wants to attend, if you have new staff that are coming in, like new leadership, they can sign up using this link, and that's also available on our website. And again, we'll send out these slides. They'll be posted on our website tomorrow, and then we'll send out the slides after all of our follow-up calls. So I know you can't click on the link right now when I'm presenting it, but it will be available to you. And that is it. Allie's gonna pull up the TB risk assessment form just so we can go through Francis's question in a second, but before we do that, does anybody else have any questions? And thank you again for the hand sanitizer feedback. Sorry, I'm being so desperate asking for it, but it's super helpful. Okay, then I'm going to stop sharing. Allie's going to pull it up and then we'll go through some of it. Okay, so this is the form, the risk assessment worksheet. It's blown up from that slide I had earlier. So you guys do need to fill this out for the relevant section. Section 1, incidence of TB. So that's where you can use that map that was on the slide. So the community rate for Chicago would be 6.06, state rate 2.78, national rate 3.0. Almost all of your facility rates would be 0 because you've not had any active TB. There are a few facilities that have had active TB cases. Your rate would be very high. I think if you have one case in a 100-bed or a 100-bed facility, I feel like the rate would be like 1,000 or something. So it would be very high just for that for your facility because it is a rate of cases per 100 persons. 100,000 people. So again, if you have not had a single active TB case, your facility rate is 0. And then can you scroll down, Allie, to the non-traditional facility-based part on the next page? Okay. Up a little bit, I think. Down a little, sorry. Okay, cool. So in this thing, so again, how many TB patients are encountered? It would almost always be 0 for you. So I see, I'm guessing this is what you're talking about, Francis. Question 2, does evidence exist that a high incidence of TB disease has been observed in the community your setting serves? So I'm going to reach out to the TB program. I'm pretty sure the answer to that would be no. Like we do have higher incidence than the state and the country, but it's not outrageous. So when I was frantically Googling during the presentation, like WHO and some of the other organizations would consider high incidence to be over 20 per 100,000. So let me reach out to the TB program because I don't want to tell you the wrong thing, but there is evidence showing that WHO would say 20, I believe, or some of the other organizations. So if you get cited or anything on that, like reach out to us and we can help. So whatever you put on there, at least have some kind of citation for it, but I would say no at this point. And then does anyone else have any questions about how to fill this part out? Oh, sorry. And then question 10. So question 10, if you have not had any cases, you are low risk. So you don't need to ask, like that's what it is. So just check low risk for that. If you have had cases, then we can connect with the TB program to see what you would put. But we have not had any, even the facilities that have had active TB cases have not really had spread. So that's a good thing. If you did have an active TB case, we would help you right away, make sure everyone who needs to be evaluated is evaluated and kind of monitor that situation.
Great, thank you.
Oh, thanks. Okay, I think that's it. Does anyone else have anything you want to talk about? Okay, well, we will see you at the end of July. Have a good summer.